Greetings. I'm Jennifer Kennedy, the lead for quality here at CHAP, and welcome to this month's CHAPcast. In today's discussion, we're going to be spotlighting some fundamentals and innovation at the same time, and I'm here with Dr. Amy Moss and Jason Banks to talk about that innovation. But before we dive in, Amy and Jason, could I ask you to introduce yourself to our listeners out there?
Yeah, thank you. Good morning, and I'm delighted to be with you, Jennifer. Amy Moss, Senior Vice President, Clinical Operations Hospice at Amedisys.
And I'm Jason Banks, Senior Director of Sales at nVoq, which is a speech recognition organization.
Thank you. It's so cool to be with you today because I know we have an exciting topic to talk about. Again, before we sort of get to what that topic is, Amy, I wanted to ask you if you're seeing challenges out there today in the healthcare landscape with physician documentation. And could you talk to us a little bit about that and what it's like to be a hospice medical director in today's healthcare landscape?
That's a loaded question, Jennifer.
It sure is.
I mean, wow. So, I think what we think of as the world of a hospice physician, hospice medical director today and 2022 has changed so dramatically in the last 5 years, but definitely in the last 10 and 15. I mean, it's a completely different ball game, if you will. The clinical component persists as it should, and it's the most important thing that we certainly need and want from our physicians is that clinical acumen. But the demands of meeting the administrative and regulatory and compliance needs of the industry have mushroomed, if you will, over that period of time. And I think one of the challenges that has come along with that is not only those of us that work in this industry day in and day out, trying to grapple with what those changes mean at the provider level when you really get down to do the work, but helping them understand what those mean. One of the salient points I came to understand many years ago is that how I was trained to provide clinical care and to document what I was doing as a physician in, just garden variety, primary care physician in a variety of settings is completely different than what we need and expect from a hospice physician. And the best example I can give to you and to your listeners that are clinicians and definitely that are physicians would understand this. We talk about a SOAP note. That SOAP.
Yeah, I know.
Right?
I remember doing them as a nurse.
Right,
I sure do.
Right. So they're very structured, right? They're subjective, objective assessment and plan. I mean, and that's what you do. When we talk about hospice documentation, but just communication around an interdisciplinary team, it really is about telling a story.
Right.
It's narrative. And, there's training programs now that do, medical narration that really just, it's an entire fellowship that talks about how do you do that? How do you tell those stories in medicine? And I point that out just to say that most of the physicians that I interact with on a day-to-day basis, but even in the industry, most of us were not trained to do that. Mm-hmm. And so it is on-the-job learning about how to really deliver on that expectation. And it is a sizable challenge, but it is an exciting one as well because it allows us to really do some very creative things in how we deliver on that. So, I think that's how I would say it is most unique today to be a hospice physician compared to 10, 20 years ago.
Right. It's I would think it's difficult to really achieve that balance that you need to tell the patient's story, right? But you still need to get all those salient things in there that, say, an auditor is looking for
Hmm.
or
Hmm.
a surveyor is looking for. So, how do you get all of that into the documentation to satisfy anybody who's going to pick that record up and look at it, right?
Absolutely. It's that that balance, juggling those, if you will, those discrete factual pieces that, a third party might be looking for. And let's be honest, it makes it easy when we have a checklist, right? That we can say, oh,
Yeah.
yes, it meets this, it meets that. We're good to go. Let's move on down the road. But all of us listening know that most patients don't read the textbooks, and most of our delivery of high quality care and delivering on a great patient experience is all in the gray.
Yeah.
And that's really a challenge. So it's finding that balance in that narration, if you will, of pulling in those data elements that are discrete and factual in many cases, and then weaving through there all of that story about the patient's scenario, their need, and quite frankly, I hats off because there are some really, really skilled hospice physician clinicians in the industry that do this just exceptionally well.
Well, I'm sure you're one of them, Amy. I feel pretty certain about that. So, with all of these challenges, it seems that you needed to take a look at your process and maybe do some process improvements. So, can you talk a little bit how you use the nVoq as a both fundamental and an innovation to your process, which in turn then spurred your medical director engagement?
Yeah, it's actually a really fun story when you go back to think about it. You know, I notwithstanding everything that I just shared, um, most of my physicians are contractors. So that means that, they're doing gig work, right?
Right.
And they might have been one of the original gig workers, honestly, when you think about it. If you think about today's workforce and what hospice physicians have been doing. But that's a really important distinction because what that means is that they have a million and one other responsibilities that are coming at them that they need to manage. And so keeping that in mind, efficiency was the need of the day, was how can we be very efficient in what we do as a hospice agency, and get the quality and all of the pieces that we need and want. And we were struggling, not unlike many, I'm sure, in finding that balance. So we would hear feedback of, "Well, I just don't have time to sit down and do all of this documentation that you're wanting, Dr. Moss," or "I'm not quite clear on exactly what it is that you need. What's the most impactful pieces that you need?" Or I'm a terrible typist. I mean, heaven forbid,
Right.
I'm a terrible typist too. And then let's just not even talk about those that were handwriting.
Yeah, let's not.
Right? But that was still happening. So, what I discovered in my travels was that, we had significant variability in how we were delivering the outcome, and there was a lot of dissatisfaction amongst the physicians. And so that's where I started. I said I need a product that delivers on. I need a solution, and is what I was looking for. And I thought back to my days of early in the hospital, and they'd say, "Hey, Dr. Moss, you're late on your medical records." And there was this old, the old dictaphone, the big clunky thing that
Oh,
you would
yeah, I
use.
remember that.
But I thought, you know what? I learned then that it created some time saving for me. So, taking that analogy, like what do we have today in the industry? And we were using some products that, were maybe kind of the I don't know, the Pinto version of some of those products internally. And it was a mixed bag of, you know, whether or not they liked them or used them. And then we also had, clinicians are really creative, so they'll figure out ways to do workarounds. And some of those were problematic, as you can imagine, read between the
Right.
lines here. And so I needed a solution that would help them and help them be efficient. And I thought, what if we could just tell the story, like narrate, like it's not remarkable. It was just kind of keep it simple, stupid
Mm-hmm.
theory, right? And I
Right.
thought, oh my gosh, so how could we do that? What would it take? And it needed to be efficient. It needed to be, I don't need to have a lot of equipment. And so, as it turns out, there was another conversation in the organization happening with nVoq, and I just happened to tag along and said, "Hey, can I just listen in on what you guys are doing?" And I needed, I think I've said this before, so it won't be new. I said I needed the Volkswagen version of the Cadillac version they were offering.
Right.
I didn't need a full electronic health record type of interface. I just needed to be able to help my physicians sit down and just tell the story about the patient. That's all I needed. And so that began our um, uh, relationship, if you will, and we started talking, and there was a lot of exploration that went on both sides. And over that time, we have created, a product that really is working well for our physicians. The feedback, remarkably, is just overwhelmingly positive. All the way from it's time saving, and they've actually used that word. Others to I can actually get it done
Yeah.
in the time in which I want to get it done. So in other words, I don't have to take it home, or I don't have to come back to it later in the week. And it's music to my ears and to theirs as well.
Right. It's like a once and done. What a great performance improvement story.
Hmm.
And
Yeah.
you're not only up in the quality proposition, but you've got efficiencies built into that as well. So
Hmm.
kudos to you for that. It's sometimes really hard to pull something off. I'm sure it took you, X amount of time, but, for you to come out on the back end and everybody's engaged and likes it and is willing to do what they need to do, that's a PI success story in my eyes, I think.
I,
So
I
let me, yeah,
Yeah,
I'm
I
sorry,
would
go ahead.
agree. No, I agree. I think there is lots of success to be gleaned from that and lots of learnings of how to do better in the future.
Absolutely. You can always build on top
Uh-huh.
of what you've got, right? So I want to shift gears and talk to Jason about what Jason, who is representing nVoq, what are you hearing from physicians about the product?
So we hear a lot of what Dr. Moss has said today. In fact, it's interesting being on the technical side, but also having served on the provider side. I've had firsthand experience working with physicians in the hospice and palliative care setting. And to Dr. Moss's point, they wear multiple hats, right? Many of them have multiple jobs, quite frankly. But
Right.
and we've talked about this before, but they're the lead clinician, they're the lead educator. Honestly, they lead the cultural tone, at least of their teams. We find that many times they do that, and then they're the lead documenter, quite frankly, because they're defining through their documentation the eligibility of the patient. I think one thing that people that are outside of the industry don't realize is that physicians are relying on information being, sent to them either via email or via phone about that patient in order to do things like define eligibility. And it's sort of a game of telephone. What we found is we have really good clinicians across the board. I'm talking about, hospice nurses and social workers and chaplains, but not all of them are great at painting the picture of that
Mm-hmm.
patient. And Dr. Moss talked about, this sort of a lot of this lies in the gray area. I've seen patients who are not short of breath, they're not nauseous, they don't have anxiety or pain, and yet they are end of life eligible. I've seen, patients who are, 107 years old and tootling around the top floor of a senior living facility with a walker, stopping to flirt with me. And, and they're not end of life, right? And so, a lot of it does lie in there. And so, back to your question, what do we hear from physicians? They love still to this day to spend time not only with the patients but with their team. Again,
Right.
they are the lead clinician. They got into this to help people, to serve people, and not just patients and families, but also their team members, right? I see physicians who love nothing more than to actually go out with a nurse, with a social worker to the patient home and really provide some education right there on site. And man, that is such a beautiful thing to see. But as Dr. Moss pointed out, you've got a lot of regulatory requirements and paperwork and other burdens that sort of get in the way. And so, one of the things that we hear from physicians that are using the product on a daily basis is they're really appreciative of the ability to save time, but also we've built in some functionality that is sort of benign reminders that they may have left out things in the note that may affect either eligibility, that may affect regulatory
Oh, that's
compliance, that may
great.
affect payment. And so, and what's nice about it is that, you know, human nature, right? Physicians are people who want to get it right too every time. And so what we saw a lot of the time before using tools like this is they might complete their CTI, for instance, and then somebody on the QA side might catch something that the physician overlooked in that CTI note. Well, it's embarrassing, quite frankly, for that physician. They don't want to miss that. Nobody does, right?
Right.
And so this is a benign way, a little nudge on the shoulder to say, hey, Jason, you've forgotten to include this in your note. Why don't you go ahead and include it before you submit it? And it's really a cool thing to see because then that physician looks like a rock star, right? They
Yeah.
they they
Yeah.
document so well every single time, even though it's a chore that they don't really look forward to. They want to do a good job. Every single one of them that I've talked to and met wants to do a good job, and this is a really sort of subtle way to enable them to do a good job without having human interaction involved in that. And so that's
Right.
that's what we're hearing a lot from
I
physicians.
love that you built those cues in as, sort of a technical add to that. And, that in my mind, when you were talking about that, it's like, oh, you've just increased consistency like 100%, if not more, right? Across the board with your physician documentation. Are there any other technical achievements that you've had to make this work for physicians to be able to tell that patient's story?
We have, we've and thank goodness for Dr. Moss and Dr. Katz and some of the other incredible physicians that work with the organization and other organizations that we've worked with as well. We built in, everything from dictionaries that are specific to hospice and palliative care to shortcuts, right? Many shortcuts, physicians are, a lot of what they will document is unique to the patient and family, but there are some things that are pretty standard overall. And those things become really burdensome, right? When you're typing the same thing
Right.
over and over and over on every patient. And so we've built, along with their help, shortcuts that would enable them to do those types of things quicker. And so, and really the product continues to grow and grow and grow thanks to our partnerships with organizations like Dr. Moss.
That is completely awesome. So, some of the things that I've gleaned here from our conversation is that the clinical needs of an organization mixing with the responsibilities of the medical director really has changed with this implementation of innovation. Yeah, and I hear you, Dr. Moss, that, medical directors that I've worked with in my time in hospice weren't necessarily trained on, what's expected of documentation, particularly from 2010 moving forward when CMS started mounting more and more documentation responsibilities on hospice physicians and medical directors. So, really juggling that factual data and the need to meet those requirements helps to weave that patient's individual and unique story. And you're doing with this innovation and this technology, you're able to do it in an efficient and consistent way. So if I could ask you, as we're closing out here, is Amy and Jason, what's one tip that you can give our listeners when it comes to getting started using a solution like nVoq?
Gosh, just one. Ugh.
Well, you can give several if you like.
So I would say some of the initial pushback when we were rolling this out was, well, I've used dictation solutions before, and the most common one was, I have a heavy accent, my dialect is unique, and it's just always been problematic. And so we specifically did a very small pilot with self-identified physicians who said, it's just not going to work for me. And we asked them to specifically give it a try. And I have to tell you, many of them were shocked at how quick the tool learned their dialect, their accent, and the efficiency of the tool. Jason, keep me honest, but was it was well above 90% on the accuracy of the capture of what they were saying. And what I learned from that is, one, come on, let's give it a try. So let's bump up my elevator speech. But two, what we really were able to take away from that is it's not going to be perfect the first couple of times that you use it. You're really going to need to use it consistently. And I think we landed somewhere, Jason, around, an average of about somewhere between 60 and 100 dictations. You get those under your belt, you're going to have extraordinary accuracy with this tool in spite of whatever dialect you throw at it. And I think that was a critical, learning for us, particularly for our physician population. And so I would say, really pay attention to the data that nVoq can help you really analyze about what the user experience is, and then turn that around to continue to leverage buy-in.
And
That's great.
I would echo everything that Dr. Moss said. One of the things that we see when it comes to adoption of the technology is just a plan and leadership and the communication plan to try it in earnest for a period of time. What we see is physicians and other clinicians who may use the tool once or twice and they have an error and they put it down. They're not apt to go back to it, but if they use it, as Dr. Moss pointed out, 60 to 100 dictations, or call it 3 weeks in earnest, 4 weeks in earnest, they never put it down again. They realize the value of it, and it's really rewarding for us because we've been in the industry a while. We know that regulatory is getting tougher and tougher. And, to your point, Jennifer, as you pointed out, there's so many different regulatory components compared to 2010, right? You've got to have that PPS score. You've got to have the disease progression. You've got to have, the prognostic statement all clearly documented in that hospice CTI. And so, for physicians who might be juggling, again, they might be juggling multiple responsibilities within the organization at the very highest level, as well as perhaps multiple different job responsibilities. Those are difficult things to be able to manage. And again, they all want everything I have experienced in almost 20 years in the industry. They want to do a good job, and they love patients and families, and they want to document effectively. And so this is just a tool to enable them to do that.
Yeah, thank you. And I'm really glad that you talked about the need for the physician to use it and use it and use it, because remember, quality improvement is not an event, it's a process.
That's
so thank you for throwing that in. Well, I want to thank you both, Dr. Moss and Jason, for joining me today to talk about this cool innovation that's available. And, it's a testament of quality improvement and process at your organization, Dr. Moss. Thank you so much for joining today. And I want to thank our listeners out there for taking time out of your day to plug into our podcast. And hopefully you are able to take away a pearl or two of wisdom from this discussion. Thanks again. Join us next time for the next podcast, and stay safe and well.